Hi, my name is Jesse. I'm with SBCC, and today we're going to be doing a barium enema. So barium enema is a study of the large bowel. It's the large colon from transverse, ascending, descending, and the sigmoid and the rectum. And so a lot of common indications are any sort of obstruction. There could be an apple quarter sign, which is sort of a cancerous sign, volvulus, intussusception, polyps, colitis, and so many more. So it's a very important exam. The doctor will have the patient prepped for you by cleansing their bowel, whether it's laxatives, flushing with an all-liquid diet, or any suppositories. And so here are my materials that are needed for the exam. Lots of towels are going to be needed. We have lube to help with a smooth tipping process. We have an air inflator to help if it's double contrast, but we're only going to be doing single contrast. I have my tip, my barium bag that holds the barium, and then the barium that's currently used. It is now currently cuffed, but when the patient comes in, I would uncuff it and bleed the line out just to make sure we're not injecting any air into the colon. But for now, we will wait till the patient gets here. So, another important supply that's always going to be needed is gloves. You want to make sure you have plenty of gloves on hand, as this exam can get very messy. Masks are not needed, but can be recommended. So, we have paper towels also. Normally what we do is we put a little bit of lubricant on the paper towel. We get our tip. We put the tip onto the lubricant, and that will help with the tipping process. And I have my table detented already, so when the patient gets in, we'll be able to perform the scout image. It's a supine KUB. And make sure we double ID the patient, check if there's any clinical indications, any allergic reactions, any contraindications. And that seems about all. I just want to mention that when the patient gets here, the bag should be hung no more than 24 inches to permit a nice optimum flow. And that is all. Now let's go get our patient. Okay, so now that we have our room set up, we're ready to go get our patient. We still have our KY, we have our hemostat, and we have our table detented. So I'm going to go get my patient now. Hi, can I get your first and last name?
Madeline Ortiz.
And your date of birth?
11/23/93.
Any chance of pregnancy? Okay, perfect. So now I've double ID'd my patient, I've ruled out any chance of pregnancy, and now, have you been explained this exam and
No.
what's going to go happen?
No.
Okay, so what's going to happen is you've followed doctor's instructions previous to this exam and cleansed yourself.
Just been on a liquid diet.
Perfect, that works. That works great. So, what's going to happen is I have some what's called contrast material that's going to help us view your large colon through some images. So essentially what's going to happen is we're going to take a scout image of your abdomen, KUB, and it's going to show us what we're going to compare to all these images that have contrast in them. So we will be, once the doctor comes in, we'll be tipping. We're just going to be inserting this, and then we're going to drain some of the barium into you while we take a few images, just to sort of get an idea of what is going on here. And once the doctor comes in, we'll be doing that. So some doctors like to tip themselves, others prefer that you tip and would like to just come in and do all of their fluoro, and they want you to have their fluoro settings ready. Some doctors are specific, some doctors aren't. So if you could go ahead and get up on here. So Normally we'd wait for the doctor, but since this is just a video tutorial, we'll get going right now. So I'll have you lay down, face down, which is prone. All right, and then we'll have her transfer into a Sims position. So if you could lean your right leg up and be careful of the fluoro tower. Lean your right leg up and sort of down on your left shoulder. Perfect. And so now is the time for tipping. We have our lube, we have our gloves to try and keep everything as clean as possible. We have this clip, and we have a hemostat to clip the air cuff. What we do is always check the air cuff to make sure it's working before. This is what's going to create a nice seal to make sure there's no back drip of barium. Now, we also have tape right here. This is to tape the leg to make sure that the tip and the tube, while the patient is rotating around, there's no pressure given on the inside area, but all the pressure through rotation is applied to the outside of the leg. All right, now I'm going to go ahead and tip. Get it nice and lubed up from the tip, and then I'm going to have you go. Now that I have my patient in the Sims, we're going to get ready to tip. I have my hemostat to cuff the air after it's inflated, and I have my tape to tape the tube to the leg to make sure that that's where most of the pressure is applied and it won't force it out. So I have my lube, and then I'm going to lube the tip up, and then we're going to get ready to tip. All right. So essentially you would give breathing instructions, make sure the patient's extremely comfortable, and then you would go anterior 1 to 1.5 inches, and then you would increase that superior no more than 4 inches. You would then inflate your balloon, and then use the hemostat to cuff it. After all that is done, you would then essentially tape it to the leg as stated before, and then you would release the barium and let it go in. And now, after all that is done, we're at some spot images, and we're going to take a total of 8 spot images. I have Madeline set here in a right lateral decubitus. I have the grid and grid holder right back here. We're using digital, so there's going to be no running of any cassettes. So, I'm going to first shield my patient. Is that okay? You comfortable? Okay. And first image is a right lateral decubitus. Okay, we're at a 90-degree angle. Our SID is 40 inches. Okay. And then we want to pull that back and center it at the iliac crest. Right about there. And so, when it comes to decubitus images, you always mark the side that is up. So this is a right lateral decubitus, left marker. And I'd shoot this one, I'd shoot a normal decubitus about 80/40, so you want to kick that up a notch considering there's a lot of contrast in there. And 90/40 to 90/50. And as I said, we're using the full 14/17, maybe even 17/17 if you have a larger patient. And we have digital, so that image has already been processed for us. Next, we'll move into an RAO. And if I could have you roll up for me. Get this out from under you. roll over into a 30 to 45 degree angle. Perfect. And I'll shield my patient. I'm back to a nice angle of 0. When moving around through all these images, you want to consistently make sure that your bucky is going to be lined up. Move the table back. And so again, for all these images, this one in particular, you want the CR to enter again at the crest, but you want to go about 1 inch, maybe a little bit more, to the elevated side. So our patient is shielded, and then we'd make that exposure. Next, I'd have you lay flat down. So now we're in the prone position. And we would just simply do a normal PA projection. Right. All right. Next we do a PA axial. So, to get the right angle, I'd actually have to wag my tube back. This is still a 40-inch SID, as the whole process is. All right. So, for this one, you want to get somewhere between a 30 and 40 degree angle. 35 seems right in the middle to me. And then with any image, after moving your tube or making an angle, you want to make sure you realign your bucky. Okay, and this one is also 14 by 17, but for larger patients as well, you can just expand that to the full 17 by 17. And this image is essentially as well, you just want to make sure that the CR exits at the as is. And again for this, I'd say somewhere between 90 kV at 50-ish mass, roughly, is a good estimate. Okay, so then now that that image is done, I'm going to move this table back up for you. You want to make sure that your patient's comfortable throughout this whole exam, as it can get very embarrassing and uncomfortable. Make sure your tube's lined back up. Great. All right, now ma'am, I'm gonna have you roll up onto your left side. We're gonna do another oblique. It's another PA oblique in LAL. Awesome. Just make sure your shield's set. Again, we're gonna enter at the crest, 40-inch SID. About 1 inch to 2 on the elevated side. All right, so you take that exposure. All right, you can relax for a moment. So then you pull out your digital plate. And then you put your grid back on, and you go for your next decubitus. Alright, if you could scoot as close to that board as possible. Okay. I get my shield sort of close to the areas there. Pull my tube back out. Line it. Get that 90-degree angle. Make sure we're centered right on the crest as well. And I'd still say for most of these, 90 at 40 is going to be a good ballpark, depending on your patient size. But your last lateral rectal sigmoid is going to be where you want your most technique. So again, decubitus, mark the left lateral, mark the side up though, to make sure it's positioned correctly. Okay, so I'd take that image. All right, ma'am, you can lean back for me just a little bit so we can get this. Make sure your bucky is back lined up where you can sit. And last but not least is your lateral rectum and sigmoid. So you want to make sure they're in a nice lateral position. You want to enter about 2 inches below the crest, I believe, is a good spot. So, for this one, we're going to enter the mid-coronal plane, of course, sort of right at the as-is, not the crest. So, I think the as-is is about 2 inches below the crest. We want to cone down to about a 10 by 12. And since the left side's down, we'd use our left marker. All right? All right, we're all done, man. If you'd like, you can go use the bathroom. So we take the tip out, sort of drain it. We put the bag much farther below this area to sort of induce some natural flow back into the bag, just to sort of help that. Now that our patient is in the bathroom, evacuating all of the contrast we put in, we sort of clean up the table a little bit, make sure the rest of the barium is thrown away, and throw away any supplies that we are not going to keep, such as dirty towels, woolen laundry, etc. And once the patient is done going to the bathroom, we're going to take a post-evac, which is just a supine KUB, just to sort of see what's left after all the images are done. And don't forget to tell your patient that gray, white, or somewhat grayish discolored stool is very normal after this. And one of the best things to do is to consistently hydrate. Drink lots of water. Never forget to tell your patient that. So this is our first image. It is a right lateral decubitus. The CR goes right at the mid-sagittal plane at the iliac crest. And it's pretty much just for critiquing the medial side of the ascending colon and the lateral side of the descending colon right there, you can see that those are the sections that have the air in them. So it's just easier to see all the house straws and everything that's going on the air side. Next in the series we have our PA oblique RAO position. This is going to be where you have your patient essentially rotate their body 35 to 40 degrees. You want to center your CR about 1 or 2 inches from basically the midpoint, the mid-sagittal plane, towards the elevated side. This projection essentially is going to open your right colic flexure without superimposition, and that's pretty much it. You can see it's marked right. You can see it's obliqued basically because of the way the ribs are pointed right here. You could also tell by the crests over here in the pelvis, and that right there being the right colic flexure is completely open. The left one is very superimposed on each other. Next up is the PA large colon. You can pretty much see the whole large colon is demonstrated here, all the way down to the sigmoid rectum. You get the ascending, you get the transverse, you get next colic flexure, and then you get your descending. Basically, you have your patient prone, and you want to suspend respiration to really minimize the movement. Next up is going to be your PA axial. It's mainly to basically critique and view the sigmoid colon area and the rectum with the S curve, which is actually labeled right here in this picture. So you're going to want to have a 30 to 40 degree angle caudad, which is towards the feet, and you'll end up with a picture that looks something like this. Luckily this one's labeled, so we see our left colic flexure, our transverse colon, and here's our sigmoid and rectum. That one is one of the tougher images to gauge for me, basically because the CR exits at the as-is, which means you have to make sure that your bucky and your tube are aligned, and there's no real entrance point because it's such a heavy angle. But you just got to look at where your light exits and make sure that your bucky is lined up for that PA. Next up in the series is going to be our PA oblique projection, and this one is in LAO position, and just like the RAO position, you can see over here where it's marked with the L, this is the left colic flexure, and this one is very well demonstrated without superimposition. You can see the transverse, and it's a very good oblique because you can still see the Scotty dogs right there with the zygomatic processes, if you will. And yeah, you just want to make sure that you still have your patient rotated about 30 to 45, and you want to have that CR essentially centered 1 to 2 inches towards the elevated side, just like the RAO position. Next in the series is going to be our left lateral T-cube. So right here we're viewing the lateral side of the ascending colon and the medial side of the descending colon. You can see they're labeled right here very well in this image. We got our descending colon right here, so there's the medial side, and then we got our ascending colon right here. And again, we're really sort of trying to view these sides with the air, and it's very important to always mark the side up. As you can see, this is a left lateral D-cube, but it's marked with the right side up. So next up is the left lateral rectum. This is pretty much for just contrast and evaluation of the rectosigmoid areas. And this is the only image that's going to be done on 10 by 12 collimation. You're going to want to center your central ray right at the as-is. And you can tell that this is a good image because, where's my mouse? Yep. Femoral heads right here are very well superimposed. You can sort of see the crests right about there, very well superimposed. The sacroiliac joint, no, not the sacroiliac joint, the L5S1 right there is open. And here's your sacrum. So lastly, we have our post-evac. After you're done with the whole rotating your patient and taking all of your images, you're going to let them go to the bathroom, and after they evacuate themselves of most of all of the barium or contrast that you are using, you're essentially just going to take another KUB just to see where you're at right there. And after all of this, it's important to make sure that you tell your patient to hydrate, and grayish whitish stool is normal for a little bit.
Now that concludes this specific barium enema series that by all means is not a do-all. It's important to check for contraindications to make sure that you do not use barium if there's any signs of perforation. And also, every doctor is different. So some radiologists may take all of these images, some maybe only want a few. It's important to pay attention to each doctor because they are different, and maybe make notes of what they specifically like for these exams. Thanks.